Good morning, everybody, and welcome in Cardio Egypt 2026. And this is 75 collaboration, celebration in the Cardio Egypt and the Egyptian Society of Cardiology. And today I will speak about when to take the adult patient in the cath lab. Actually, the introduction, our colleague said a lot of information, but the cath lab remain the fundamental modality in the diagnosis of the interventional treatment in adult congenital heart disease. To the non-interventionalist, there is perhaps less appreciation in the diagnostic cardiac catheterization in patient care. Currently in United States, more than 1 million patients have a congenital heart disease, and moreover, a meticulous approach to every cardiac catheterization procedure is mandatory to avoid missing unrecognized congenital lesion presenting in the adulthood. So when we take our our congenital adult case in the cath lab, either for the diagnostic purpose, for estimation the pulmonary artery pressure and pulmonary vascular resistance, as just Dr. Ragab said, or in determination the shunt amount and the degree of the shunt by calculation the QP and the QS and the intracardiac pressure in the different cardiac chamber, or in the other entity to intervention. Intervention, we have a lot of type of intervention for adult congenital heart disease, either for their initial defect or residual defect after catheterization or after surgical intervention, or palliation procedure. We have a lot of palliation in adults, or acquired heart disease as post-myocardial infarction VSD. We can take the adult patient for VSD transcatheter closure. Shunt closure, either ASD, PFO, and now venosus ASD. We have a joint session tomorrow for a joint session with the PICS for VSD, for sinus venous ASD closure. Please join that. And we have also VSD and PTA closure. This is example for a transcatheter ASD closure in adults, and actually all of us know that we start by crossing the VSD and parking the catheter in one of the pulmonary vein, then exchange the system with the delivery system over the exchange stiff wire, putting the device and then release the device. All the procedure during ASD closure is transesophageal or transthoracic echo guidance. And the venosus ASD, we have, I just said, a joint session tomorrow, inshallah. And regarding the VSD closure in adults, we just do a ventriculogram first. Also, there is a technical problem in the movies, I'm sorry. And then we cross with the wire, snaring the wire from the right side and do a VSD closure in antegrade fashion. And when we are happy with the device position and there is no residual flow, we can release the device. VSD closure can done also retrograde. So we start by also ventriculogram, then we cross from the systemic side and we can put the device retrograde without doing a complete atrioventricular loop, and it looks easier, but it must be using the double disc device to doing retrograde approach. In adult also we can close the PDA, but sometimes the PDA in the adult patient come with a pulmonary hypertension, so also using a double disc device to secure the device position is a wise option in adult PDA closure. This is one entity. Other entity, in spite of closing the defect, we can creating a shunt. As my colleague just said, we can induce, we can create a shunt at the atrial level in two situations, either in the right side pulmonary hypertension to relieve the pressure in the right ventricle, or also in the some cases of HFpEF and diastolic dysfunction in the left ventricle, also to relieve the left ventricular high pressure. Or we can also create a put shunt in between the descending aorta and left pulmonary artery in some highly specific cases, or we can enlarge or augmented or creating a VSD in some cases of door with restrictive VSD, but it's also need high selective cases as VSD creation is highly risky. Also, we can dilate the obstructive lesion in adult, either dilate pulmonary stenosis or coarctation of the aorta, but dealing with the adult, it looks some different issue. At the annulus here, it will be bigger than the available balloon. So double balloon technique is a wise option also in adult. In adult, we can use double balloon technique by two methods, either using the multi-track, which is mainly designed for the mitral valve veloplasty, or using double venous access from the right and the left, and using two wires and the two balloons and simultaneous inflation of both balloon, we can get the results. Also in adult, we can dilate coarctation and putting the stent. in the cath lab. I'm very sorry. I'm very, very sorry about the technical problem with the movies. But for securing the time, we can pass it. Also, we can intervention in the cath lab after doing other intervention, like that case. This is after glam procedure. We can appreciate the right pulmonary branch ostial stenosis, so we can go and dilate this is ostial stenosis by balloon and then putting the stent in the cath lab also. We can doing pulmonary valve implantation, which is a new era after tetralogy of Fallot. We can appreciate the free flow across the pulmonary valve. We take the patient in the cath lab and putting a lot of type of pulmonary valves now available in Egypt. We have a venous B valve, Sabian valve, and my valve. And this is after the results is very well, and also because securing of the time we can go. We can also take the adult patient for tear repair, either for the mitral by mitral clip or in the tricuspid position, especially in the TTGA, to avoid the severe tricuspid regurg. We can put valve in valve or valve in the ring in the also mitral and tricuspid position. New era in the aortic valve disease, away and beyond the TAVI. Now there is a Jiva valve which can put in the aorta because of the severe aortic valve incompetence, not the stenosis. Also, we can put TAVI in congenital bicuspid aortic valve, which is also a new, it's not the start of the TAVI. We can create a Fontaine transcatheter also in the adult congenital heart disease, or we can close the fenestrated Fontaine, which is sometimes the surgeon leave it as a vent for the Fontaine to be successful. And this is the closure of the fenestrated Fontaine using the PFO device. In some cases of DTGA also, we have a two type of HL switch, and we have a puffles which sometimes come with a complication, puffle leak or puffle stenosis. We can dilate the stenosis, the puffle stenosis using a balloon, and we can close the puffle leak using also a PFO device. A special care for adult congenital heart disease patients which come to us during pregnancy. During pregnancy, the intervention need highly expertise, need low dose of radiation, and we here can depend on the non-imaging as non-radiation imaging as echocardiography in the, using eyes or transthoracic echo. Also, a protective shield in the back of the mother is highly important for baby protection. Also, we use the AB view as the lateral and oblique view have a lot of radiation scattered in the cath lab, and please do it in the second trimester, avoid the first trimester because for the high teratogenicity of the baby. And thank you very much. I'm sorry for the time. I'm very sorry.